the U.S. healthcare system looking around the corner, and Paul has added key trends and implications for supply chain professionals. My name is Dennis Orthman, and I'm a Senior Director with SMI. Today we have almost 100 connections across the country participating in this session, and SMI is very thankful that you could be part of today's webinar. Before I introduce our speaker, I'd like to just go over a few housekeeping items. First, all attendees for today's sessions are in listen-only mode in order to eliminate any background noises and ensure the audio clarity. The voices that you hear today are my own voice and the voice of our presenter, Paul Keckley. We are interested in your questions, though, and our webinar technology allows attendees to submit questions using the questions feature in the control panel. You are all encouraged to submit questions at any time during today's session. When Paul has finished his presentation, if time allows, I'll read the submitted questions and Paul will try his best to answer them. We expect today's session to be approximately 1 hour in total, depending on the number of questions submitted. The slides you will see today will be emailed to all attendees after today's session, and we're also recording this webinar, and SMI will make this recording available to our members on demand via our website. Lastly, at the conclusion of our webinar, all attendees' screens will automatically be directed to a post-webinar survey via the GoToWebinar system. I want to encourage you to complete the survey, as the feedback from all attendees is an important component for SMI in our program. Now I'm pleased to introduce to you our presenter, Mr. Paul Keckley, PhD, creator and producer of the Keckley Report. Paul is the publisher of the Keckley Report, a widely read weekly report on the pertinent healthcare policy topics. Paul is a former managing director of the Navigant Center for Healthcare Research and Policy Analysis in Washington, D.C. Prior to joining Navigant, Paul served as executive management at Vanderbilt University Medical Center, where he led strategy. He started the Center for Evidence-Based Medicine in the Vanderbilt Center for Integrative Health. Paul brings extensive experience and expertise to our session today, having published more than 200 studies and 3 books that are addressing industry issues. During the period preceding the passage of the Affordable Care Act, Paul facilitated a series of meetings between the White House Office of Health Reform and major health industry trade groups, as private sector input was sought in the legislative process. Paul is a regular contributor to network and business coverage, whether it be the New York Times, CNN, Wall Street Journal, Fox News, Financial Times, and others. Paul currently serves on numerous boards. He's a member of the Health Executive Network, the Nashville Healthcare Council, and a collaborator with the Bipartisan Policy Center in Washington, D.C. Paul holds a Bachelor of Science from Lipscomb University in Nashville, Tennessee, a Master's and PhD from The Ohio State University, and did a graduate fellowship at Oxford University in the UK. With that, I'll turn it over to you, Paul, and thank you for being with us today.
Oh, it's my pleasure, Dennis. I noticed you put the D in front of Ohio State. I never really understood that, but I think they're pretty adamant about that. Dennis is going to advance slides as we go through this, and those of you that were at the meeting last month know that I prefer that about half the time be open Q&A, and so I'll move through these things with dispatch. But I do think there are some things that have actually moved around a bit since we met, and I'll update you on a few things. So, Dennis, if you'll advance to the second slide showing these forces of change.
It's up there.
The point I want to make here is, if you look at these, what tends to change in healthcare very, very fast, and what obviously impacts supply chain professionals is the clinical process. The approaches we take with our clinical diagnostics and therapeutics, the drugs that we're purchasing, it's kind of terrifying to know that we have 29 new cancer drugs in late stage of approval at the FDA, each of which is going to carry a price tag of over $100,000 for a course of treatment. So clinical processes tend to change in this industry very fast. The obsolescence of our technologies are really faster than most other industries that we can compare to when we look at financial services or manufacturing and so on. Now, all of that comes to bear on the supply chain professionals who get pressured to buy stuff. And then, on the other hand, you have these limiting factors. The delivery system doesn't change very fast. There are lots and lots of vested interests that kind of are an anchor to keep it from changing too fast. So while clinical innovation is changing fast, the delivery system doesn't change fast. The federal government is playing a bigger role in trying to align delivery system change with clinical innovation. But if anyone imagines there's a parallel or some kind of synchronicity of the two, you're just not going to find it. The slide you see next that shows these circles was a slide I created for a Vanderbilt program where we brought MDs and MBAs together, and our medical students were allowed to get an MBA degree if they could understand every sector that you see in this ecosystem. The point I think is important for all of us that look from the outside in sometimes at the industry is this industry has done well, averaging annual spending increases of almost 2.5% above the GDP. The question I asked the group last month is, why does healthcare as an industry do well when the rest of the economy isn't? And how does healthcare do better when the rest of the economy is doing well? And the reason is it's because we can. And now there are new forecasts that say healthcare spending is going to accelerate again. It's going to hit a 6% annual clip. Now, all of you are following these reports of economic recovery. We went into our downturn in 2007, as you know. We bottomed out in 2010. In that period of 5 years, healthcare spending slowed to 4% a year. But put that in a context. The overall economy tanked. The GDP was about 1 to 1.5% per year. So here's the bottom line. If you look at this next slide, you kind of see the gist of this. Healthcare spending is going to be the rule of the realm. And the Affordable Care Act comes along, and you can see this pyramid. And this is kind of a really simple view of a very complicated process that was undertaken by all industries to protect a private system of health while increasing access and reducing costs simultaneously. And the thing that I'm reminded of is the president in the first Monday of May of 2009, he had a photo op with the heads of the pharma, device, bio, AMA, AHA, and AHIP organizations, the 6 big trade groups. And in that photo op, it was on the heels of a meeting where the 6 groups agreed that the healthcare system was not sustainable, that it had to change. The political calculus was that the Democrats were newly in office. If you recall, when the president was elected, the Democrats controlled both houses of Congress, and he had promised health care for all. So the compromise between industry and policymakers, the elected officials in 2009 that led to the passage of the Affordable Care Act is what you ended up with, a very imperfect law, a compromise between the private sector, these trade groups that said, we don't think the country is ready for Medicare for all. We don't think the country is ready for a single-payer system. We don't think that it could be passed in any sort of an election. So middle ground is let's change the way the system operates. And what you see in this pyramid is kind of the two sets of fundamental changes that happen. And I want to provide this a bit as context because I think it's definitely changing the landscape for the supply chain professionals in this industry. It makes your job more complicated. It makes it more important. It certainly expands the scale and scope of your responsibilities. So let me just kind of unpack this a bit. The law said we've got to essentially change the business model in the insurance industry so they're not rewarded for withholding care. So it created a number of requirements, quote, effective on enactment, effective 180 days from passage, eliminating pre-existing condition, and so on. And then to keep the insurance companies honest in the law, there were these, what turned out to be very problematic changes, like these health exchanges that the states were to set up and operate. And basically the federal government was going to backstop a few of the states that couldn't do it for themselves. But politic as it is, as you know, we ended up with 32 states that decided to go with healthcare.gov because the states said, we're not going to set up our own exchange. You had hybrids in 10 other states, and then you had 8 states that did it on their own. Over the next 18 to 24 months, it's highly likely that healthcare.gov will be in place in every state. In states where, like Kentucky, the exchange was set up and where numbers of people were enrolled, a new governor has said that's going to be dismantled, which means it defaults to healthcare.gov. So as you see on this slide, on the insurance side of the Affordable Care Act, the intent was change the business model, standardize the products using essential health benefits, state insurance commissioners to make that happen, and create competition. That's what the premise of the co-ops was. Remember the 23 new consumer-owned and operated plans that the federal government loaned $6 billion to start. We only have 10 of those 23 left standing today. It's very unlikely that the co-ops will survive another year. So on the insurance side, health reform has had a fairly spotty track record so far. We're 4 years into the changes on the insurance side, and you're going to see a lot of interesting unintended consequences on the insurance side, none the least of which is a pressure point for all of you, which is it's produced this accelerated consolidation in the insurance industry. As we're here today, we're waiting on DOJ to chime in on Anthem's acquisition of Cigna, on Aetna's acquisition of Humana. The 36 Blue Cross plans are acting more like a single plan. So between the Blues, United, Anthem, and Aetna, you've got more than 80% of the insurance market controlled in the hands of 4 organizations. Obviously, they need better deals from providers. They're going to be pressuring with tougher negotiations. And they have produced some very handsome profits for their lenders and or shareholders over the past few years. The insurance industry has not been harmed to this point by the Affordable Care Act. It has had the effect of consolidating that industry, and now that industry is using its cash on hand, which is substantial, to diversify or to enter into a number of joint ventures with provider organizations. The most prominent of those you've read of lately are Aetna announcing a joint venture with Texas Health Resources, announced 2 weeks ago. Aetna has a similar deal with the Nova Health System. Anthem is doing deals in California in a joint venture model called Vividity. And then you're seeing that in other parts of the country. So that's kind of the insurance side of that pyramid. On the delivery system side, it's not as clear, nor is it as simple as the changes on the insurance side. On the delivery system side, the simple way to understand the goal of the law was eliminate fee-for-service incentives and replace them with something called value, whatever we can calibrate value to be. Second, let's standardize care around the evidence. That's the reason 3 sections of the law set up mechanisms for standardizing care. You'll see that in this pyramid in that second from bottom tier, comparative effectiveness. And the law puts a lid on how much will be spent on health care at 1% above the GDP. So the net result of the changes brought about by the Affordable Care Act are that we've had a repositioning of the insurance industry with stronger national players who are quickly moving from targeting employers to targeting Medicaid, Medicare, and individuals as a market. We have these marketplaces that are faltering with some structural flaws, and the individual market, as a result, the individual insurance market, basically unstable. The 12.5 million people that are purchasing policies through these exchanges, 83% of them expect to get a stipend from the federal government to help pay their premium, but now we've got court challenges to that, and we've got some questions about the sustainability of individual policies on the exchanges. What's that mean? It means the CFOs in our organizations are imagining more bad debt. It means that large numbers of people will enter or re-enter the ranks of the uninsured, given the volatility of the individual insurance market. And as you know, we had some promising news over the past couple of years, bad debt going down. This year, if you look at all the hospitals, down to 4.3%. That's a pretty good number, but it looks like it'll start going up again. On the delivery system side, it's more complicated. The various pilots and demos that have been done to address eliminating fee-for-service and going to value, like accountable care organizations, bundled payments, avoidable readmissions, the comprehensive primary care initiative, and so on. Most of those results are incomplete, but there's a flurry of activity. Only 1 out of 4 of the Medicare shared savings programs, that's the ACOs that you hear about, has saved any money after 2 years. And most cases, the savings were because they operated in markets that were very inefficient and high cost, so there was some low-hanging fruit. So I would say on the delivery system side, we're a long way from knowing how this is going to play out, but it doesn't appear Medicare is backing away from those initial aims of changing the incentives, standardizing care around the evidence, and putting a cap on spending at 1% above the GDP. So I'm going to skip down, Dennis, because you're going to be sending these slides to everybody. I want to skip down to, you're going to see a slide there of tipping points. You see that slide? And I want to kind of unpack that about kind of what to watch for.
I've got that slide up, Paul, just so you know.
Great. Thank you, sir. You know, as we talked about in the actual meeting, things in healthcare are volatile, and there are a lot of things that could change dramatically how all this plays out. And most of you live and work in the provider world. So is there some sort of a grassroots Occupy healthcare movement afoot that's going to expose all of our negotiations, all of our business models? I think that's a certainty. number of software programs that are being circulated, funded by private equity, that attempt to expose what it cost you for the widget, or what the total cost of care is for a knee or a hip. So there's a grassroots movement funded primarily by investors to expose the true cost of healthcare. And it's very difficult to talk in terms of cost shifting or underpayments from Medicare and Medicaid that are then upcharges to the commercial market, or how PBMs and GPOs work. But that's really what is embodied in that first one, this Occupy Healthcare. The second that's relevant to supply chain is the increased demand of employers for reference pricing for bundles. All of you know that there are 48 bundles that have been identified by MedPAC, which advises Congress, where, for instance, we're going to couple up all the DRGs that are involved in a particular diagnosis or a particular intervention, like AMI or any one of the others. And employers are saying, you know, we like this idea of bundles. We think knowing what the lowest costs are for all the elements associated with a knee replacement or heart failure, and being able to pay one price, a reference price for that, is a pretty good way to go about buying healthcare. It puts all the big ticket items out there for comparison. And then what these large employers are doing is saying to their employees, look, the reference price for a knee replacement is about all in for all the costs associated with the hospital, the post-acute provider, the physicians, the rehabilitation team, and the OR. The all-in cost of that's $26,000. If you choose to have it where you are, fine. You just pay the difference. That's driving a lot of employer activism that will, I think, be pretty relevant to how supply chain has to be thought through. As I mentioned, we've got some court challenges that could exacerbate especially the individual insurance market, driving up some bad debt, changing the way the insurance companies are behaving. And we also have, very relevant to this group, is interesting challenges in consolidation of hospitals. And you saw a prior slide about consolidation. It's across the board, but to give you a little inside baseball, the Department of Justice has historically kind of paid attention to health plan consolidation. The Federal Trade Commission and states' attorneys general, I hope I said that right, they have kind of picked on the hospitals and hospital consolidation. Well, we have an interesting shift going on. Now we've got Department of Justice tiptoeing into consolidation and antitrust on the hospital side. And we have more challenges to that now popping up. We expect to hear any day around the deliberation in Chicago with the North Shore folks. So expect more court actions to make more uncertain how consolidation in the industry plays out. One of the key selling points in consolidation has always been in convincing the regulators that if we come together, we have more purchasing power and we have more clout, and that is being questioned. Can you validate that there are synergies in the supply chain as a result of two organizations coming together? The physician discontent I mentioned because here's a factoid that's almost staggering. Today, 245,000 doctors are employed or somehow managed by the hospital. That means supply chain responsibility just widened. It means that all of the activities in these medical practices becomes pertinent to the role of supply chain in the organization. But supply chain on the medical practice side is in many ways a very different beast than supply chain in the conventional, the 3,400 community hospitals. We're dealing with a wider range of vendors, in some cases bad contracts. So this is tangling up supply chain in ways that are going to be very difficult to unbundle, and it's time consuming because as practices come under the umbrella of the hospital, it means you have to actually sit down and explain, after you understand what they've gotten themselves into in their agreements, then you have to work through those contracts. And then lastly, for the supply chain world, I've never seen as much activity around fraud and C-suite misconduct and questions of inappropriate influence on purchasing. And this is kind of brewing kind of under the radar right now, but can we demonstrate in all of our purchasing activity that this was done in a fair and balanced way? And can individuals be held accountable for civil, if not criminal, intent where purchasing agreements were not done in a way that was on the up and up? So as I thought about the meeting, I was trying to think, when I was at Vanderbilt for all those years, and I told Dennis this in one of our discussions, the supply chain folks were, if things were going well and we were purchasing at the highest level of efficiency and accommodating need of the clinical enterprise, then the less we heard from the supply chain folks, the better. We'd have our Monday 3 p.m. meeting, and we'd talk about our numbers, and we'd get some market basket and medical inflation updates and things like that. But it was only when there was a problem with a vendor or it was a new clinic that came online where the role of supply chain kind of became much more pertinent and relevant to day-to-day brush fires. And I think that's one of the unfortunate parts of the job. If you're doing your job really, really well, you're probably not getting a lot of attaboys. And that's probably because the C-suite is thinking, as long as that's operating well, the less said, the better. We need to move on to other things like growing the enterprise or this or that. I think that's going to change. I think the role of supply chain, this first point here, I can't state it strongly enough. Institutional solvency and sustainability is going to be measured and achieved on a matter of a few basis points. We've got 1 out of 4 hospitals that's teetering on the brink of insolvency today. We're operating 2.6 beds per 1,000 population. Clinical innovation is going to move us closer to 1.6 over the next decade. An interesting study out just last month on the efficacy of total joints being done in outpatient freestanding ambulatory surgery centers at a fraction of the cost. So how we purchase those prostheses and those elements of our enterprise that relate to the direct cost that you control, that you manage, is going to be much more in the spotlight. The second point is this is getting more complicated. In addition to the physician element of this, we have to be mindful of the post-acute environment. Here's the important thing. In all of these savings programs, like bundled payments, about 40% of the savings in the bundled payment programs, if you look across all 48 of them, about 40% of those savings come in the post-acute world, what happens after a person leaves the hospital. So we have much more integration of the post-acute world with the acute world, and now we have the consolidation of the two, this integration of post-acute with the acute. Again, when you go to trade association meetings like American Healthcare Association, AHCA, and all these others, you see a whole different set of vendors. The GPOs obviously trade in this area, but it's a much more complicated and a wider market than most of us cut our teeth on. The third point I made there is that we think the vendors are fascinated by finding new ways to do business and recognize that the gig is up in many ways. Congress, for instance, is trying to investigate and be more aggressive about GPOs. We've got some major device manufacturers that have announced they're going direct to their providers instead of going through GPOs. So we think you have to be mindful of the fact that while we're having this call today, the vendors in the supply chain are trying to figure out a new business model for themselves, obviously while going through their own set of consolidation. And then you see the last point there, the regulators are watching all this. We're a highly regulated industry. What makes healthcare weird is that regulation varies by sector. Each of our sectors in healthcare, I kind of measure 17 sectors and try to monitor them day to day. Each has a different set of regulations. Each has a different balance between state and federal. And each sector has a different set of federal agencies and programs. And as all of you know, there are about 300 federal programs that directly or indirectly oversee healthcare. So it's just getting more complicated, and we've got some have called them Navy SEALs in the federal government, just looking to find areas that they can come after healthcare professionals, especially in the provider space. So this is the kind of my take on kind of where this is playing out for the supply chain. I think I'm now, Dennis, on the implications. The new rules in the market are changing by the day, but we're clearly seeing a need for much more attention to transparency. All that can mean is, all of you know, 2 years ago, for the first time, Medicare unlocked the box so that anybody, Joe Sixpack, can know every nickel Medicare spends on every doctor and what drugs they're prescribing. Everything about what we're doing, including your deals, your contracts, is now under scrutiny. And that's the reality of this market. And it's not going to get any clearer or any easier. Second, the supply chain world has some interesting entrants. So the obvious set of entrants that 10 years ago, when I was at Vanderbilt, just doing ops, we were just starting to get our arms around all of the technologies, all the information technologies that had to be considered part of our supply chain, and the interaction between the CIO and now the CMIOs and our procurement processes was very clunky. We have a range of new competitors coming to the market who want to go direct to a doctor or direct to a consumer with supply and procurement opportunities. And that's going to make this market really, really messy. I'm following pretty closely right now the geneticist and the genomic testing and how that's entering markets and how organizations interface with that. Third, the new ways of doing business, that relates specifically to this, that payers are going to look for total cost of care instead of unit cost. That's a key distinction. Payers, Medicare, employers, Medicaid agencies in 39 states, Medicaid is now outsourced to private Medicaid managed care plans. Payers are looking for new models for expecting, predicting, and paying for total cost. So your cost will increasingly be embedded in a bundle, and those bills that we produce with line items become less and less the focus of how a payer is looking at this. And the second dynamic is the vendors that we purchase from are looking for new business models. The most prominent of these are shared risk arrangements with the drug industry, where they're saying if you put our drug in a more prominent position on your formulary, and this is especially true of level 2 and level 3 in the formulary, if you give us more prominent position in exchange for volume, we'll give you greater discount, or we'll share in whatever outcome improvements result from using our medication and whatever upside you have in a payment. It gets very complicated. So the vendors and the payers are looking for new ways of doing business. Mm-hmm. And last, this train left the station. It just doesn't appear any of this is going to turn around and we're going to see back to the good old days. For me, that means everything about supply chain activity is now sitting prominently in the C-suite as a senior management focused day-to-day, and not enjoy, and I think this is to our detriment, not enjoy being able to do its job well, and not, it's kind of like leave well enough alone. I think those days are gone. I think it requires supply chain to be sitting in the C-suite, because these questions are coming fast and furious from the vendors, from the payers, and I think we've got to be ready for that. So I'm going to stop there. Dennis, let's just open it up to questions.
Paul, this is excellent. I've got a number of questions that have been submitted. These first two came very early in the presentation when you were talking about the Affordable Care Act. The first question was the Affordable Care Act, in your opinion, intended to shrink the size of the healthcare marketplace?
Interesting question. Great question. It was intended to reduce the cost while utilization was increasing. So let me unpack that a little bit. All the numbers show that best case scenario, demand for healthcare services will continue to increase. Demand in terms of units of care that are provided, whether that's visits, tests, admissions, all that stuff. What was intended was that the cost of each unit go down while the numbers of units purchased was going up. That's the reason in the law it says we're going to slow healthcare spending down to no more than 1% above the GDP. Instead of flat to the GDP, 1% more than GDP. So healthcare market grows, utilization increases, demand increases, but what we pay for each widget goes down. That was the intent of the law.
Okay. Here's another question that came in, do you think that the Affordable Care Act two aims, and I wrote myself a note, which were to reduce cost and to cover more lives. Do you find those two aims are in conflict? It's a related question.
Interesting question. Great question. I mean, this is good stuff. Yeah, bottom line, it's really interesting. I was in the middle of all that stuff in the White House, and I remember the first time the president said we'd have to reduce cost and cover everyone. And I thought, wow, okay, how are you going to do that? And as it turns out, it's all front-end loaded. In order to reduce cost long-term, you've got to make more investments in the short term on more preventive health, on more diagnostics, and much more aggressive early childhood, mental health, et cetera, substantial investments in primary and preventive health, a new model of primary care. So, yeah, I think they're in conflict if you try to imagine that you can do them at the same time. There's a natural order of this. You have to make investments in the system up front to bend the cost curve long term. And I'll tell you something anecdotally, Dennis, since you're a good New Englander. Massachusetts health reform, which was one of the two models that was kind of used as a basis for this. The Massachusetts model did not have as an intent to reduce cost. It had as an intent to increase access. So they increased access to insurance in the state of Massachusetts from the high 80s up to, at one point, it was near 97%. Mm-hmm. And the theory of that is if people have access to insurance, then they'll not be dissuaded from seeing a doctor, and instead of putting off something, showing up in the ED and having expensive treatment and having a $4,000 expense. The Affordable Care Act has lots of hanging chads. I mean, I've got my own list. I read it about every 2 months. I go through it again and again and again. One of them is they tried to sync these things up as if you could do them in parallel. I don't think it's possible. Just don't think you can do it. It's a great question.
Yeah, I think that question was a reflection of what I hear from our members many times. They feel being pulled in different directions.
Yeah, you are.
Yep.
And mm-hmm. The fact that most of these little volume to value things that we're trying, we cut and pasted them from things that Medicare had done. Medicare bombed on the physician group demonstration projects. Guess what? That's the prototype for these accountable care organizations.
Yeah.
And the ACOs are just not doing well. There's a lot of activity, but some of them aren't doing well at all. And then you have the newest iteration, the MACRA. Congress passes this deal paying doctors differently starting in 2019, and it disallows, if you're in the alternative payment program, it disallows participation in the ACO. So it's kind of like Congress said, okay, in the Affordable Care Act, we're going to push everybody into ACOs and do a lot of bundles and shift all these incentives. Hey, they're not working. We're going to pay doctors differently, so don't do that. Do this. It's rope-a-dope. I mean, it's rope-a-dope.
Mm-hmm. Well, we had another question that was submitted, Paul, and I know this was on when you had the pyramid up on the screen and talking particularly around comparative effectiveness. And let me try and bring the pyramid back up again. The issue, I think, for many folks in supply chain, and the question was, in what forms do you think the comparative effectiveness effort will surface? And I think in the supply chain, because many people, since this term was introduced in our business, folks involved with supplies, whether you're purchasing them or inventing and selling them, have been waiting for this comparative effectiveness, thinking that it's it's going to tell us not only what is the best way to care for a patient, but comparative effectiveness could also yield which product is better type of an announcement. And yet we've not seen anything.
Yeah, let me just assure everybody that you haven't missed something. Okay. This thing has had a bumpy start. It's under the auspices of the Patient-Centered Outcome Research Institute, PCORI, that was funded in the law starting in 2012 with the expressed purpose of making all this comparative effectiveness research accessible to Joe Sixpack so you can make a reasonable judgment about what works. The law disallows any correlation between what works and what it costs. Okay? That's a key determination. The law says that we're to make publicly accessible information about the efficacy and effectiveness of drugs and devices, therapeutics, diagnostics, all that stuff. It disallows any direct connection of any of that information to what it costs at any level of granularity. So for supply chain people, it's going to be distractive. There's going to be an increasing amount of information out there about this drug is 15% more efficacious than that drug. But it will be in the private sector. A lot of these investor-funded, web-based startups with a cloud-based data repository that somebody takes the CER data and then matches it to a claims database and says, so here's our prediction of what it should cost in Boston or Des Moines. There is no direct linkage between the comparative effectiveness research and cost, period. None.
Got it. I know everyone is on mute, but I think there might have been a little sigh of relief right there.
Yeah, well,
so
they've had fits and starts. It's run by a fellow named Joe Selby, who was at Kaiser. Good guy. They got plenty of money. They got tons and tons of people working on this stuff. But it took, I did a study on this a few years back. There are analogs to this in other countries, and it took them 20 years to set up a CER program. I mean, we've got it in France, we've got it in England, we've got it in Australia and Germany and so on. Canada has a version of this. It's taken them 20 years to do it. We're just now into our fourth year, and we don't even have enough good data. So we're nowhere near having this ready.
Okay, great. And I've got what I think is a great question towards the end. When you were talking about the implications, you're talking about Occupy Healthcare and employer activism. You mentioned there are grassroots efforts to expose the true cost of healthcare today.
Yeah.
And when you made that statement, this question came in that said, if those grassroots efforts are underway, how should supply chain safeguard its supply chain data, or should we continue towards transparency?
Great question. It's better to move toward transparency, and here's why. Many of these, one, it's going to increasingly be regulated. It's going to be exposed by employers as they're negotiating with their employees. But more importantly, a lot of the data that's out there from these online tools that are investor funded have bogus cost data. So you err on the side of misinformation if we're not transparent. And I've seen it. And the hedge there for this would be a great thing for the SMI to think about, or each organization to do on its own. Find some graduate students in economics or business or something, and as a summer program, have them equip you and sign up for all these services, all these people that are really ready to give you what costs are from these online tools that you can download. And I don't want to get into a legal, I don't want to get in trouble on this call. I can name some of these that are crazy. I mean, some of the data they're putting out on cost, you go, I beg your pardon?
Yeah.
and you wonder where this stuff comes from.
Mm.
So my sense is we have to err on the side of transparency, because there's so much out there in blogo land and on online land that's just bogus stuff. And
That's
it's
good.
unfortunate, but that's reality.
Oh, that's great. Paul, I'm going to bring us to a close with one last question, and this is my own question. Do you see a day in the near future where partnerships between suppliers and healthcare providers may look like partnerships in other industries? And the example I'll give is it's not uncommon today with an organization to hear, the New England Patriots, the official car of the New England Patriots is a Lexus. Or will we hear something like the official implant of General Hospital is Acme brand? Will we see that type of, you think we'll see that?
Absolutely. I mean, it's just the nature of our market. And, I'm thinking here's an example. I expect at some point we're going to hear, see on websites and in physician recruitment and payer contracting, we're going to be touting that we're part of the Epic system. And because we're part of the Epic system, we have access to a number of cloud-based tools that are letting us do this or that. It's not surprising. Mayo is working with 35 independent systems around the country, kind of touting its brand and some of its stuff. So, we're going to do that. I don't know that everybody will have logos all over their uniforms like the NASCAR folks, but we're going to get there.
That's good. Paul, this has been wonderful and very insightful. I want to remind our attendees that we will be sending out the slide deck to folks, and you'll get that later on this afternoon. And also at the conclusion of this webinar in just a moment, our attendees will automatically be sent to the survey site, and we encourage you to fill out that survey. Paul, on behalf of
Dennis,
SMI...
if anybody else has any questions, just have them bump a note. I'm happy to. I'm just a geek, and this stuff is fun. So if I can help, just let me know.
We will do that, Paul, and I'll remind folks of that when I send the slide deck out. Paul, thank you so much. It's been helpful. SMI's enjoyed both your forum presentation and your webinar. And with that, we'll come to adjournment. And I want to thank everyone. And with that, we'll end the webinar. So again, thanks everyone very much. Thank you, Paul.
Thank you, everybody.